We can start the webinar, our webinar. This is a series of spine updates. And this time is we have very distinguished guest, Edward Benzel. And our main talk will be about the importance of spinal biomechanics. And we will discuss it on the cases and also first after a talk on spine biomechanics. I will give the words to our moderator, Dr. Onur Yaman. He will continue.
Can you hear me now?
Yes.
Yes.
Welcome, everyone. So we're going to talk about spinal biomechanics impact on clinical practice. So we have great names here, especially at Benzel. We have learned lots from him. So he's going to talk about principles of spine biomechanics. Ed, if you're ready, you can start.
You can share the screen.
Ed?
I am. I'm trying to share the screen.
Yeah, good.
Okay. So I'm talking for 15 minutes. Is that correct?
Yeah, that's correct.
Okay. Principles of spine biomechanics. There's a lot of material here, and it's kind of hard to squeeze it into 15 minutes, but I'll do my best. We must realize that the youthful disc, when compressed, increases the osmotic pressure within the disc, and when the pressure is released, the osmotic pressure declines. This helps pump nutrients into the disc. We humans, Homo sapiens, are the only animal, if you will, that walks completely upright. All the rest of the animals pictured here are either walk on four limbs or are knuckle draggers. Life is kyphogenic, and so is surgery. We tend to disrupt the integrity of the spine with surgery oftentimes, which causes it to bend forward. And we can see how this gradually occurs with time, as depicted in this picture. An important concept is that of coupling, a phenomenon whereby a movement of the spine along or about an axis obligates another separate movement along or about another axis. So in this spine, we have a scoliotic picture. And if we bend our spine to the left, the cervical spinous processes move to the right, and the lumbar spinous processes move to the left. So if we're going to place screws into this spine, we must be cognizant of this rotatory component and henceforth place the screws at an angle on this patient's right and almost straight in on this patient's left. The fundamental cartoon of what we deal with is this one. It's a force that is applied at a distance d, creates a bending moment, which is the product of the force times the distance. That bending moment causes a concentration of stresses ventrally and then causes them to propagate dorsally as the spine rotates about the instantaneous axis of rotation. So we see all of this in sagittal plane and coronal plane as depicted here, and we're looking for stable and neutral vertebrae. What we don't want to do is to stabilize up to a kyphotic segment, because we will increase the tendency for deformity, and henceforth we would more appropriately instrument on this long construct to above the apical vertebrae. There are two junctional zones in the spine, the cervical thoracic junction on the left and the thoracolumbar junction on the right. The thoracolumbar junction is very variable and changes gradually from vertebrae that have no ribs or no rib attachments to the L1 or L2 region. Conversely, at the cervical thoracic junction, we have an abrupt change in dynamics that are at the C7T1 junction, going from a mobile cervical spine to a relatively immobile thoracic spine. This causes a lot of stress at this point and can lead to failure. And if we're not cognizant of this and inappropriately apply instrumentation, long instrumentation down to C7, we could end up with injuries or deformities such as this. Again, the thoracolumbar junction is gradual, and it has its own set of a huge set of problems that we face in determining length of construct, where to stop, where to end, etc. If we think of the vertebral body as being 3 by 3 by 3 Rubik's Cube, we can then divide it into segments, and this would be akin to removing the middle third of the cubes would be akin to a compression fracture. The one on the right would be akin to doing an ACDF or corpectomy, excuse me, in the cervical spine, where we leave lateral aspects of the bone present, or a lateral extracavitary approach, as we see here, removing dorsal bone but leaving ventral bone in place. Again, we must be cognizant of what we're removing when we are doing surgeries such as a lateral extracavitary and more anterior approach. And in the cervical spine, leaving lateral bone so that a bone graft is snugly placed, not only at the end plates above and below, but laterally with the retained bone. I call this the Erlenmeyer flask approach, where we can do this decompression at an angle and get a wide decompression, but through a relatively narrower corridor. Again, this would be akin to a lateral extracavitary approach, where we leave a lot of the Rubik's cubes and replace the ones that we remove with some sort of a strut for stability. We must keep in mind that vertebral bodies change considerably from the top to the bottom. Here we see the width and depth increasing significantly until we get to the bottom, where we see the depth of the vertebral body starting to diminish a little bit at L5. Same with the ventral height, begins to change, become a little bit smaller, the dorsal height, as we come down through the lumbar spine. Compression strength increases, but at L5, it's a little bit less than the spine above it. And with flexion and extension, we can see that we have a lot of flexion and extension mobility in the cervical spine and the lumbar spine, but very little lateral bending because of the sagittal orientation of the facets in the lumbar spine. The interspinous ligaments, the ALL, PLL, etc., strength varies considerably. And in the lumbar spine, the interspinous ligament is relatively weak compared to the other ligaments. However, it works through a long moment arm and henceforth is a valuable ligament regarding the preservation of stability in an uninstrumented spine. We tend to think of the motions along or about the Cartesian coordinate system and the the centroid of that system is the instantaneous axis of rotation, which moves. It's called instantaneous. It moves with loads. In this case, for example, it moved dorsally. Archimedes said, give me a lever long enough and a fulcrum on which to place it, and I shall move the world. Bending moment is the product of force times distance. I've already mentioned that the greater the bending moment, the greater the stress, the greater the chance of failure, as depicted in this cartoon. So with subaxial spine failure, we tend to think of the different types of models, the Denis concept, the Louis concept, Bailey concept. But in reality, we tend to think of anterior, middle, and posterior columns. But if we want to simplify, this pretty much tells the story. The ventral column has been fairly disrupted in this particular situation, and we should treat it accordingly. You don't always have a bending moment when a load is applied. This is a load that has no moment arm. It's direct compression and compression only. The spine can still fail, but it takes a much greater force to cause a bursting fracture than it does to create something like this, because there's a bending moment applied. And then finally, we have the chance fracture, which is centered ventrally, say at a lap belt in a patient without a shoulder harness, and then causes a distraction and flexion injury, which can be pure bony or partially bony and partially ligamentous. We can also see this equivalent injury with the shoulder harness in the cervical spine, as depicted here. The orientation of the facet joints are critical. In the cervical region, they're coronal, and in the lumbar region, they're sagittal. This affects motion. And for example, in the lumbar region, there's very little rotation because of the sagittal orientation. We can distract the spine, we can apply three-point bending, we can apply compression, and we can utilize a variety of cantilever beams to restore function. We should be aware of the stress-strain curve, in which there's a neutral zone with very little load causing significant displacement, and then the elastic zone in which there is increasing amounts of load applied, causing greater motion. The slope of this curve is stiffness. And here we see neutral zone, elastic zone, and we start beginning to deform here in the plastic zone, and then ultimate failure. My last concept here has to do with strength, which is proportional to the third power of the diameter of a rod, and stress, which is the equal to the bending moment over the strength. Implants always fail at the point of maximum stress application. This is a very weak portion of the rod, so the plate, so the strength is small, and the loads can be great. So this is a screw that fractured at the plate. It is a constant inner diameter screw. This screw is a tapered inner diameter screw and fractured distally. This one fractured here because the bending moment is greatest at the plate, and henceforth it will fracture there. Why does this screw fracture near the tip? Because even though the bending moment rises, the strength increases exponentially as we pass along the screw, and henceforth we tend to see a drop off quickly, and the maximum stress occurs somewhere near the tip of the screw. This has been a whirlwind tour through this, and I apologize for rushing a little bit, but I tried to provide everything in my biomechanics book in 15 minutes.
Ed, thank you so much for this presentation. Everything was fine as usual. I have a few questions. You have told us that in a deformity in a spine in the thoracic area, it moves to the right, and the lumbar area, it moves to the left. Is there a reason for it? Do we know that?
Yes. The reason is that the orientation of the facet joints and the presence or absence of the uncovertebral joint in the cervical spine. If you take a spine model, you can do the same thing. You can bend it. You can bend it and actually see the rotation that occurs because of the orientation of the facet joints.
Another question. Do we know the exact level for the thoracic spine if you start from the sacroiliac joint? Okay. There is a common question.
You know what?
To pass the thoracal. So if you start from the sacroiliac joint, okay, can you recommend us? It's a title that Olvan is discussing about it. Is there an exact level for the thoracal lumbar junction that we have to stop? Okay, let's say you're doing a lumbar deformity. Okay, so we have to decide according to the apex of the curve. We have to consider the sagittal balance. So is there an exact place to stop for the thoracal lumbar junction? Is it T12? Is it T10? Is it T11?
Absolutely not.
Yeah.
There have been hundreds of papers written on that very question and how to answer it. And there have been hundreds, maybe thousands of failed surgeries because the estimation of the length of the construct was not accurate. So we still have not figured this out. I will, if the vertebrae seems neutral and the levels above are without a significant kyphosis, I will stop at L1. But then, a fusion from the sacrum to L1. On the other hand, that might be uncommon if there's a significant kyphosis there, and they may want to go up to T10 or T9 to get to a more neutral vertebrae.
Yeah. Again, we don't have exact vertebra for the cervicothoracic junction. It will depend on the patient's position on the deformity, but can you say something about the cervicothoracic junction? You're doing a cervical deformity, okay? It depends on the thoracal kyphosis. Again, it depends on the lumbar lordosis, especially for the cervical deformity. But is there a vertebra that you determine this will be the best, or you have to consider these parameters to stop at the cervicothoracal junction? Does it have to be T4? Does it have to be T5?
It really depends on sagittal alignment and the SVA, this spinal vertical axis. In other words, that latter entity is the distance, the sagittal distance between C2 and C7, or C7 T1. They should be relatively, there should be a relatively small, less than 10 centimeters SVA. If not, this is potentially the problem you're dealing with is potentially a upper thoracic or cervical thoracic, not a cervical problem. So the objective of surgery would be to neutralize a pathologic SVA. And this often requires going down into the thoracic spine with potentially facet osteotomies, or even in severe cases, wedge osteotomies of T1.
Thank you so much.
Basically a PSO.
Yeah. So if someone has a question, please write on the right block here so that we can ask it. So any recommendation? Any comment?
Are you asking me?
There is one more question. How do you decide neutral vertebra?
It's the vertebra in which the disc above and disc below is relatively not flexed or extended, not kyphotic or not lordotic.
Yeah, Ed, thank you so much for this nice presentation. I think we can pass to the second speaker.